Well, thank you for the honor of being here. It's a great pleasure to be at this conference. Actually, it's failing heart rather than ventricle. I have no conflicts related to this talk. So I'm going to start off actually with some of the principles I will use in my other two talks. So it's a little bit more general than this one, but I'm going to be using these same concepts as I build my other talks. So the basic approach I think of when I manage an unstable patient, I go to something very simple, which may surprise you, but it's Poiseuille's law, which is that a change in pressure is a flow times a resistance. So that means that blood pressure is essentially blood pressure as related to cardiac output times the systemic vascular resistance. Now it's a delta pressure, so you have a downstream number that we put in there, but it's small and we can ignore it. So the implications of that simple relationship is that a decrease in blood pressure or inadequate perfusion is either because the cardiac output is decreased or the systemic vascular resistance is decreased. It has to be one of those two. So that's where your differential diagnosis begins at the bedside. An important principle too that I want to emphasize, because we often forget about this at the bedside, and that is that cardiac output determines the blood pressure. The blood pressure does not determine the cardiac output. That could be the subject of another long lecture. So blood pressure is cardiac output times systemic vascular resistance. What do we actually measure? Well, the blood pressure was measured. That's why you got called. But you also either measure or assess the cardiac output of your patient. One of the speakers said before, a very important monitor, look at your patient. So the first question you really ask in resuscitating somebody is the cardiac output decreased, in which case that is the problem, or is the resistance decreased, which you ended up figuring out because the cardiac output was normal. So that becomes central in your diagnosis. So if you can actually measure it, as other speakers have said, that gives you a really powerful tool to direct where you're going with the patient. So cardiac output itself is related to two things: cardiac function, which you've heard somewhat about today, and the return function. Cardiac function is heart rate, stroke volume, and stroke volume is afterload, contractility, and preload. The return function is stress volume, compliance, resistance, and right atrial pressure, which is common to the cardiac function and return function. So this talk is about the cardiac side of that. My talk tomorrow will deal with the resistance side. So here's the simple model that I think of. There is the return function, which is the tank filling the heart with a stress volume and an unstressed volume draining through a resistance, and the cardiac function, which is the Starling part of the curve, which will be today's talk. But I will briefly go through the return function because we need that, because that determines what's coming back to the heart. So thinking about how does blood actually get back and go around again? Volume creates force in the veins, a venous elastic recoil. So here is an elastic structure, a balloon filled with volume and a clamp at the end. And if I release that clamp, the balloon can empty. What are the principles affecting this emptying? Well, they're really quite simple. First of all, there's a volume that's left, the unstressed volume that had to just get the walls stretched, and that's the part that came out. There is a compliance, a stretchiness of the wall, and there is a resistance draining it. So the simple relationship is the stress volume divided by the compliance and the resistance draining that region. Importantly, only about 30% of your blood volume is stressed. The rest is unstressed and does nothing. So somebody my size, that means 1.3 to 1.4 liters are doing the work, the rest is doing nothing. And the compliance is a relatively constant value. Now if I put more volume in and double the volume, then I have more to come out again. And that's what we frequently do with our volume management. We're just increasing the elastic recoil in the veins and venules and then increasing the rate of return back to the heart. Now, how does the heart come into this? Well, the heart is at the downstream end. So what the heart does, it allows that downstream pressure to fall. So it has what I call a permissive function. It allows the recoil to occur. Now, of course, it has a very other important function. It's permissive, it's restorative rather, in the sense that it's got to put it back again or you won't have any flow. But a crucial part of what the heart does is simply allow the veins to drain. If you have a patient that's arrested in front of you, and then you cut a large vessel, they bleed without the heart beating because that's the elastic recoil emptying out. Anybody who has a halal or kosher food, that's a crucial part. You have to cut the veins to let the blood empty because it won't come out unless you allow it to drain to atmosphere. Now, the compliance in vessels and veins is constant, but the compliance in the heart is time varying. So cardiac structures, the compliance varies over time. So on each beat, the ventricles become stiffer and then relax. And that's actually how they empty. And we call this a time-varying elastance. So if I have a heart that constricts, it's becoming stiffer, is what's really happening. If it's clamped, I have a rise in pressure without a change in volume, but if we allow it to empty, then each time it empties, it squeezes the blood out of the chamber. So there's a change in pressure with a change in flow. So the rhythmic decrease in compliance transiently increases the pressure in the heart, and that's what ejection is all about, with valves making sure it goes in the right direction. So we have a cardiac function, which is Starling law, with preload setting the position on the curve. And we have this return function for the blood coming back to the heart, and these two intersect to create the working point, which is the cardiac output, the venous return, and the right atrial pressure. Now the pressure difference from that tub, that tank that fills the heart, is very small. It's only 4 to 8 millimeters of mercury. So small changes downstream with breathing or changes in heart function can very significantly affect the return of blood to the heart. Now, a crucial point is that the contraction of the heart occurs with calcium entering the cells, and there's a fixed time for that to occur. So this shows you an action potential, and in this case, this light signal is the movement of calcium into the cell followed by contraction. So you have calcium enter, and you get your tension. But there's a fixed period for that to occur. And the plateau of the action potential sets the time that calcium can go in and make the contraction. So it's a very fixed period. So why is that important? Well, it's important when we come back to this time-varying elastance of the heart as described by Suga and Sagawa. So this shows pressure on the y-axis, volume on the x-axis, and we start off with the passive filling curve. As you fill the heart, it's stretchy, and it stretches with a fairly linear pattern, but then it becomes really stiff because you hit the limits of the pericardium or the cardiac cytoskeleton itself. Now what Sagawa did, he took rabbit hearts and he put a balloon in the heart and a really high fidelity pressure monitors so that he could measure the pressures instantaneously at different times. And he filled the hearts up to different volumes, just as Starling and Frank did. But he could measure the pressures at a fixed time after the onset of contraction. And he found that he would do this, let's say, for 60 milliseconds, and all the points landed on one line. And then he would look what's happening at 100 milliseconds, at 140 milliseconds, 180 milliseconds, and at any given time, from any given initial volume, all these points land on the same line. The slope of this line is elastance, or 1 over compliance. So as I was saying to you, what your heart does, it gets stiffer and then relaxes. The importance of this, there is a maximum to that curve for any given cycle. And that's because the calcium went in and is removed and it can't go anymore. So this becomes the maximum stiffness the heart can have in that beat given all the starting circumstances. And that is the best measure of its contractility and its function. So that's the end systolic pressure-volume relationship, which is elastance. So the end systolic pressure-volume relationship is the maximum elastance or stiffness the heart can obtain in the time available for each cycle. You can't go past that line because everything is retrieved and turned off. So there's two types of ventricular failure. One is forward failure. It's the failure to generate forward flow, an inadequate cardiac output because of that. And the second is a decrease in heart rate because of decreased contractility or increased afterload. Sorry, decreased heart rate, decreased contractility or increased afterload. There's also backward failure, which is reached when you reach the steep part of that diastolic pressure volume curve. That could be because of abnormal diastolic function, also because of failure to empty. So if you start with a high volume, then you got a lot less left over at the end, and just straight volume overload when we give them too much volume. So going back to this time-varying elastance, and this picture, these were all isometric. There was no emptying. But when the valve opens it, I lost a slide actually. So if we decrease the contractility, that means we couldn't get to that same stiff final point. And so our maximum point is now lower, which means the stroke volume is always going to be lower because I can't get to as high a value to empty. So forward failure occurs because the heart cannot reach as high an end systolic pressure volume line in the allotted time. This is one, got out of order. So to empty, this is what would occur. When I got to 140 milliseconds, instead of going all the way up, the valve opens and I get a stroke volume. If it went to 100 milliseconds, now I have more time to empty, I have a bigger stroke volume. If I get to only 40 milliseconds before the valve opens, I can have an even bigger stroke volume. So this shows you that important point that I'm sure all of you know, the less the afterload, the greater the forward flow, because you have more time now to have that ejection. But you still always end up at the same final line, you just have more time to get there as you eject. So on that previous slide, as I showed you, if that end systolic pressure volume line is lower, then the stroke volume is going to be lower. So the lower the pressure at the aortic valve opening, the greater the stroke volume, because you simply have more time to get to that final elastance. So this is the classic pressure volume loop. You start off with diastolic pressure, which is your preload. The valve opens, which is approximately the afterload. I put it in quotation marks, but it's pretty close. You eject to that final line, and the slope of this line is contractility, with a stroke volume out and the stroke volume back. You have to remember that we sort of forget about this, but you put out a volume, but in the steady state, exactly the same volume must come back to the heart at every single beat in the steady state. And the ability of the heart to handle that becomes a very important part of what it can do. So in the steady state, stroke volume has to equal stroke volume return. So just taking that contractility failure point again, so here is a heart. We had different preloads, the same afterload approximately, and as we fill the heart up, as in the classic Starling's law, we get increasing stroke volumes. We can draw the classic Starling curve by taking those points, and we get this rising output to a plateau because we've reached this steep part of the passive filling curve. So this is the classic Starling curve with its plateau. So each of those points on this curve. Now remember, there's a plateau to that, and Michael alluded to this in his talk, that once you hit that plateau, more volume will not help. And it's flat, because this part is steep. It does not creep up, and there is no value in right heart failure of trying to jam in more volume. It will not help, and only cause harm. So the significance of the plateau, once reached, further volume loading does not change cardiac output. This is a diastolic limitation. Now, going back to forward failure, I said to you before that a decreased heart function is a flattening of this end systolic pressure volume line. So what that means is the stroke volume has to be decreased because it can't get to it doesn't have as long to eject. And on the cardiac function curve, that produces this downward rightward shift, as was shown to you this morning, or this afternoon, I guess. So this actually looks the same if you increased afterload, decrease heart rate, or decrease contractility. All three look the same on the cardiac function curve. So you have a lower stroke volume and cardiac output if the heart rate is constant at a given preload. Now, the importance of the Frank-Starling relationship. It's not so much actually the preload itself. It lets the heart adjust what's coming back to what has to go out. What Starling said was the greater the stretch of the heart wall, the greater the force produced, and the greater the output. And Michael showed a very nice figure of this. Preload is the force which sets that initial length before the muscle contracts. So it's preload that is actually the pressure, not the volume. However, the volume and the stretch creates the preload based on the stretchiness of the heart. Now, why is this law so important? It means that what goes in will go out. So here's an example. Consider a situation in which the stroke volume of the right heart was 101, and that of the left heart is 100. A 1% difference. Pretty good, huh? Imagine if your car is that precise to 1%. And the heart rate's 70 beats a minute. In this situation, in an hour and a half, your total blood volume would be in your lungs. Just do the calculation. 1 ml per beat, 70 beats a minute, work it out. An hour and a half, your total blood volume is in your lungs. It has to be perfect. It can't be off at all. That's what Starling's law does. It makes it perfect. What goes in must go out. It's the fine-tuning to match inflow to outflow. And that's really where that, not for generating the big outputs. Here's a most dramatic example of this that I've had in my career. It was a 42-year-old woman with influenza A. She had a progressive decrease in her cardiac function. She was transferred to our hospital and had a right ventricular and a left ventricular device put in. She had complete loss of ventricular contractions. She was on renal failure, on continuous venous hemofiltration. And 2 hours after the pump was in, she had this situation. A PO2 of 30 on 100% oxygen. And it just so happens this is a Thursday night, and we change attending staff on Thursday night. So I come in at this point, and this is what I'm facing as I come in at 5 o'clock on a Thursday night. She's got pink froth pouring out of her endotracheal tube. Her central venous pressure is over 20, and it doesn't make any sense. She's got these two mechanical hearts. They shouldn't be failing. How can this be happening? And why is the CVP so high? And actually the pulmonary artery occlusion pressure as well. So we tried to figure out what was happening, but surgeons being mechanical, their solution was, well, let's add another machine. And they thought of putting her on ECMO to try to deal with the lungs, but they couldn't do it with the circuitry, so they wanted to take her to the OR to do that. So they're going off to the OR as the internist is trying to think. This is her chest x-ray. They go to the OR, they open her chest to redo the tube. Suddenly her PO2 increases dramatically, almost immediately. The pink froth stops coming out. What happened? She was an example of exactly the problem I was just describing. The LVAD drains, so in this situation you have both. So you have a right heart pumping blood into the lungs, but you drain it from the left heart, from the left atrium, and then put it back in the aorta. So that drain from the pulmonary venous system was probably kinked due to probably the mediastinal edema. When they opened the chest, they unkinked it, and now it wasn't a problem. This is the example of outflow not matching inflow. So this increased pulmonary venous pressure produced massive pulmonary edema, and she was in trouble. And this is her x-ray. 2 months later, she walked out of hospital alive and functioning. Now, what are the implications of overfilling? Michael already alluded to this. We've already talked about the plateau of the cardiac function curve. So when you overfill the right heart, you begin to displace the septum into the left heart. And what that does, it compromises function of the left heart. So a very dramatic study by Atherton et al. Lancet in 1997, they took some normal subjects and subjects with decompensated heart failure, applied lower body negative pressure. In the normal subjects, as you expect, their left hearts got smaller, but in the patients with decompensated heart failure, they actually got bigger or stayed the same and functioned better. So there was a comment about a downward part about a Starling curve. There is no downward part of a Starling curve, but if you overdo filling, you depress the cardiac function curve, and it will look like a downward part to the Starling curve. It'll effectively function that way. Again, a dramatic case. This was somebody with an overdistended right heart, has a cardiac output of 4.7, a little on the lower side, but still okay. Central venous pressure of 15. I aggressively added furosemide to this patient. She hadn't been peeing, but I doubled the dose up to big ones. I think I gave her some metalazone and albumin, and she starts to pee. She puts out over 4 liters that first day. What happens? Her pulmonary artery occlusion pressure falls, her CVP falls. 8.8 liters in 3 days, just with diuretics, not mechanical methods, and her cardiac output actually rises to 7.1. You make it more efficient simply by diuresing her. I'm going to skip this slide. Yeah, this last slide. I'm going to skip that one. too much. Okay, so just finishing off, factors affecting filling, diastolic compliance of the ventricle, pericardial limitation, heart rate. Heart rate's a very big factor. Going back to that fluid case that I showed you, the heart rate was only 65, 70, which means the heart's really filling and reaching the limits of its filling. Volume status, we as clinicians, if we pour in too much fluid, that actually affects it. And of course, the systolic function of the patient also is going to affect what you're left with at the end. So just to finish off, arterial pressure is flow times resistance. Resistance, causes of a low resistance, sepsis, drugs, spinal injury, those are big three. And you could treat those with drugs that affect resistance. On the cardiac output side, you have circuit problems, which is mainly the stress volume. You fix that with volume, but norepinephrine can also recruit some unstressed volume into stress volume and help you. And then, of course, if it's the heart itself, if it's low cardiac output, then the issues are fix the heart. And the way you do that is you fix it with dobutamine, milrinone, or epinephrine, and you can have targeted therapy to go after the problem that's in front of you. Thank you.